Yeah, so it's very extreme swelling. It's often like well-defined margins and pockets. Okay, some common causes of lymphedema. Cancer can cause lymphedema. It's usually the treatment of cancer that causes lymphedema because cancer spreads through the lymph system. So if you have a stage 2 or higher cancer, they often will biopsy the lymph nodes. And if they suspect the lymph nodes are involved at all, they will remove them, which then will reduce lymphatic flow or circulation. There's some inherited conditions, and then there's some cases where the lymph nodes themselves can become infected and therefore blocked, and then it will cause lymphedema distal to that area. So the number one treatment for lymphedema is compression therapy. So again, they will benefit from a pneumatic compression pump. They then will have compression wrapping. And then eventually when their limb is a normal size, they will be fit for a permanent compression garment. If you don't wear the garment, the swelling will come back. There's also a specific soft tissue mobilization technique called manual lymph drainage that we will do maybe this term, but next term. And it's basically you're just stretching the skin, and you do it in C or J motion. And the difference is you actually go proximal to distal because you have to open up the proximal areas before the fluid, you can push the fluid that way. You start proximal, open up that area, and then move distal. And actually, I think this actually was a picture of, this could have been like an hour later after the manual lymph drainage. It works that quickly. Wow. However, it does take doing it for at least about 30 minutes usually, depending on how large the area is that's affected. So it is kind of a long process of the manual treatment, but it does work really, really, really well.
But you won't have a permanent change.
Yeah, unfortunately, I mean, there's some cases where if the infection is cleared, it can get better, but usually it's a permanent condition and you should permanently wear compression garments. But there's lots of people who go undiagnosed and they actually think they're just fat, and they don't realize it's actually like a fluid buildup. And yeah, I had like an instructor in grad school who's gone all over the world to treat people, and like people are just like crying and sobbing all the time because they were living for years this way and had no idea there's something they could do about it. I've treated one lymphedema patient myself, and actually she had it for a long time. It was kind of an idiopathic cause, and it was just in one lower extremity. But then she got a knee replacement, and the MD didn't think to tell her, like, hey, be careful, this is going to cause a lot of swelling. So, like, her lymphedema came back, like, with a vengeance. And she just had this huge leg, and she's just had a knee replacement, and she actually was receiving PT, but they couldn't get any knee range out of her because the swelling was so bad. So we treated her lymphedema, and then we could treat her knee. We had to get that swelling down first, and she couldn't fit into her compression garment anymore or anything. So we had to get her back.
Well, what is that?
Thank you.
I'll come back. We are going to learn how to wrap lymphedema patients, but again, we're going to do that next term. So again, compression therapy, educating them on elevation, and then educating them on adherence to their wearing their compression garment. Questions? Okay, get ready for the gross stuff.
Sweet.
Wound care.
Bring it on.
You,
See if I get it right. I know, right?
You can't gross me out.
Okay, so when someone has a peripheral vascular disease, they're at risk for developing an ulcer or a wound. Wounds can also be because of pressure ulcers. You can also have wounds because of diabetes. And the last thing we're going to do, which will be next week, is talk about burns. So, in order to understand wound care, we have to talk about the main organ involved, which is
The skin.
the skin. So, our integumentary system is our largest organ. If you remove the skin, it would be 68 pounds of our body weight.
Put that in the weight.
It involves 3 different layers: the epidermis, the dermis, and the hypodermis.
The load.
Okay, so here's a picture of our skin. The epidermis is a very thin layer. You then have a large dermis section that contains a lot of our proprioceptive organs. And you have a lot of nerve endings in the dermis. And then you have the hypodermis, or the subcutaneous layer, which is mostly comprised of fat and vasculature, and it's where the nerves originate. Subcutaneous tissue will also include muscle, bone, and tendons. Now, a lot of wounds are classified by which layers of the skin are affected, so that's why you have to know these layers. Because depending on what type of tissue is exposed, that will give the wound a different classification and possibly a different treatment. So the epidermis is our outermost layer. It actually, within itself, has 5 sublayers. It regenerates itself every 4 to 6 weeks. There's constant cellular turnover in the epidermis. The type of cells that make up our epidermis are mostly keratinocytes. We have melanocytes, Langerhans cells, and Merkel cells. What do melanocytes do?
Make you tan.
Skin pigmentation and UV protection. My nemesis.
Eat more seafood.
Let's get more.
No. It contains a natural sunblock.
You can't prescribe seafood over
I recommend. Okay, so this is an important part of the role of the epidermis and the skin in general. The epidermis is a protective layer against water loss and physical damage. Because what we need to think about with wounds, just like anything else, okay, what's damaged, what's impaired, what's going to be the result of that? So if our epidermis is damaged, we have an issue with water loss. The key to wound care is all about balancing hydration levels. You don't want anything too dry, you don't want anything too wet. If enough of the skin is damaged, the patient is very prone to developing dehydration. You can't prevent the water loss. Okay, our dermis is mostly comprised of collagen and elastin, and then just a general extracellular matrix. Again, this is important, collagen and elastin. So if the dermis is damaged, what might happen to the patient as a result? Loss of range of motion, because if the skin can't move, because the skin loses its collagen structure and elasticity, then the underlying structures aren't going to move either. Okay, as I mentioned before, this layer also contains blood and lymphatic vessels, nerve fibers, hair follicles, sweat glands, and fibroblast cells. Fibroblast cells are going to create the collagen. Okay, so again, if this layer is damaged, it could potentially very painful. There could be hair loss, loss of the ability to sweat, and loss of the ability for the skin to regenerate itself. Okay, so not only does this layer supply nutrition because of the blood vessels, it's its main source of structure and strength of the skin. So mobility is going to be compromised if this area is damaged. And just like any other tissue, when tissue is damaged, we recreate it, we relay down collagen, you end up with scar tissue, and scar tissue is not as strong or as mobile as the former collagen. So we have to work on scar management so that the patient can maintain their range of motion. Okay, last we have our hypodermis, or the subcutaneous layer. This is adipose and various connective tissues. This is where the major blood vessels originate, and then they get smaller as they go up into the dermis. Same with the lymph vessels and the nerves. The main role of the hypodermis is insulation, shock absorption, and mobility again. Okay, so if you have scar tissue in this hypodermal layer, it could potentially adhere to muscle or bone, and then again, it's going to greatly restrict range of motion. And again, if enough of the skin is damaged, the patient is prone to hypothermia because they lack this insulation. Okay, so this brings us to the summary of functions of the skin, and we've already started mentioning some. Number one is protection. It keeps outside organisms out. Also protects us from any sort of mechanical injury and prevents loss of water, electrolytes, and proteins. Skin also serves us for sensory perception. It contains nerve endings and some of our proprioceptors for pain, pressure, heat, and cold. So pain, pressure, and temperature. So if those are damaged, you're at increased risk of further damaging the skin because you can't feel. Our skin also serves the purpose of thermal regulation. So our blood flow through the skin helps with thermal regulation. But then also just the insulation helps as well. So if we get too hot, our blood vessels will dilate. Versus if we get cold, the blood vessels will constrict. Okay, the skin also helps with excretion, so it transmits trace amounts of water and body waste to the environment, which again helps with thermoregulation, electrolyte, and hydration balances, and helps to prevent dehydration. So if you don't have, the skin gets damaged again, you're going to have more fluid and electrolyte loss. Metabolism. Our skin creates vitamin D. The only thing my skin does better. So the paler you are, the more efficient you are at synthesizing vitamin D, therefore you don't have to be in the sun as much. Well, actually, you can't be in the sun. Okay, and then we can also actually have some absorption through the skin, which is helpful, as you know, if ionto or photoresis. So,
Like that.
I scanned some pages of a book that I think are helpful for reference, and I put it on Canvas under your lab section. I titled it Wound Care Reference. I recommend downloading that, and it contains a lot of this information just in nice, colorful tables and charts that you can study from. Okay, wound healing is just like healing of any other tissue. Another term, what's it, 3? 4?
It's just a blur. It's just a blur.
So we have inflammation, proliferation, and then remodeling. The skin in general, because it has that high turnover rate, heals quicker than any other tissue. But most of the time, the patients that you're going to see and treat for wound care are going to have delayed wound healing for various reasons. So they will not have the normal healing process. Okay, so oxygen is always helpful. More blood flow allows for more oxygen to reach the wound bed, which will help speed up the process of proliferation and then remodeling. Oxygen also has antibiotic effects, help resist bacteria. But one thing that can happen is if we have excessive swelling in that area, or we have the presence of too much dead tissue, it'll make it difficult for that blood and oxygen to reach the wound bed. So what we need to do is reduce that edema and remove the necrotic tissue to promote wound healing. Okay, so know that edema and necrotic tissue block oxygen from reaching the wound bed, therefore will delay wound healing. So that's one place where we can intervene to help with the healing process. Remember I said it's all about moisture balance. You don't want it too dry, you don't want it too wet. So adequate wound hydration is the most important external factor responsible for all optimal wound healing.
What's that look about?
So, if there's been a break in the skin, we then need to protect that area. It no longer has the protection of when the skin was intact. So we always cover the wound with some sort of barrier that will preserve the hydration level. Okay, so we want to limit fluid loss from the wound surface. But at the same time, the skin right next to the wound may have the risk of becoming too moist. So the skin around the wound is referred to as the peri-wound. Anyone know the term for when the skin becomes too moist?
Blister.
Maceration. Blister is a different physiology. Okay, so we have to, this is what they're referring to here, is making sure the peri-wound does not become macerated. Macerated tissue means it's too moist. It often is white in color and softer than normal. If the wound has a lot of moisture coming out of it, that's referred to as exudate. So the moisture that comes out of the wound is exudate. And if there's a lot of exudate, we have to make sure to put on a dressing that will absorb it, so the wound does not stay too moist. Because if it's too moist, it's like basically a breeding ground for bacteria. That's what you have to do when you remove the dressing. You have to observe the exudate and note color and consistency and odor.
Smell, taste.
And amount, not taste. Okay, nutrition plays a huge role in wound healing. If our patients are malnourished, their wounds will not heal. So they need all their vitamins and minerals. case I want to see anything about any of these. Okay, so wound characteristics. This is going to be in your lab on Tuesday. This is everything we're going to note about the wound. Okay, so there's a lot of little details to document about wounds.
Be objective.
Yeah, this would all be objective information. Okay, so obviously you have to note the location, and you have to be very specific about the location. You are going to always measure the size of the wound. They actually make sterile rulers, so you can actually touch the wound. Otherwise, you would just use your regular tape measure and just hover over the wound. But you always do length and width, and then you actually also have to measure depth with a sterile Q-tip. But sometimes there's tunneling.
So they don't
That too.
just a regular Q-tip and then measure it, or
Yeah,
we
it's
don't
like a
have
long
like a.
tip, yeah,
it's
Q-tip,
not like
and you
hash
stick
marked
in, and
with
then
measurements.
Then you see how far deep it went in, and then hold it up against the ruler. These days, you always take pictures of the wounds, and there will be a picture of the wound documented in the chart.
Ron, Q-tips with measurements on it.
Well, no, you usually just stick in the Q-tip and say, okay, that's where it ended, and then
Well, I
hold
mean,
it up.
for his next $1 million
Oh, for his
invention.
next-
Oh.
Yeah.
yeah.
Let's go see. Ooh, like
Measurable.
the Kuhler.
The Kuhler.
Okay, so that's what it's referring to as tunneling, undermining, and sinus tract. So undermining is when the edges of the wound collapse in, okay, because there's tissue degradation right underneath the edges of the wound. Tunneling is where there's a wound, but it's under the skin. So part of the epidermal layer is still intact, but the skin underneath it has degraded. Because we have natural, like, cavities in our body and our skin. Or sometimes the bacteria just ate through one layer. I treated a woman who, in her ankle, and we have a lot of natural sinuses down there. And so she had a wound here, and then there were lots of tunneling there.
Undermining, is that like a crater? Like cratering? Is that?
It's just where the edges, or it's like the
picturing.
tissue underneath the edge of the wound is gone, so the wound edges kind of flap over.
Okay.
So it would be, it's not quite as deep as tunneling, but it's just at the edges of the wound. Okay, you always note the shape of the wound. So a lot of what these characteristics are going to tell you is they're going to give you information about the etiology of the wound or the underlying pathology. So is it a venous ulcer? Is it an arterial ulcer? You can tell a lot from the edges of the wound and the shape and the location, actually. You have to document what the peri wound looks like. So is the peri wound intact? Is it macerated? Is it dry?
Red.
You always are going to note color. Again, and that actually will have a whole other slide on that. So we'll color. But color is going to be most important at the wound base, or what we call the wound bed. Okay, so you know if there's a presence of necrosis, eschar, or slough. So eschar is just dead, dry, necrotic tissue. And slough is yellow, dead cells. So moist, yellow, dead stuff. So this is where
Still
color is
eating
going to
over
play